The Prediction of Violence on Audio Digest Psychiatry, Volume 24, Number 15, with Philip J. Resnick, Professor of Psychiatry and Director of Forensic Psychiatry at Case Western Reserve, Cleveland. Dr. Resnick begins with a look at the incidence and demographics of violent behavior in the U.S.
White men in the room have 1 chance in 131 of dying by homicide, and black men 1 chance in 21. The chance of a sexual assault for a woman, based on victim surveys, is 25 to 30%, although the crime statistics don't reflect that. 83% of you can expect to be a victim of violent crime, and that includes having your home broken into as well as your person, like a personal robbery, assaulted. I'm going to initially go over with you some basic demographics of violence, and that is, this is before we get to mentally ill people. These 8 risk factors I'm going to share with you now simply predispose to violence, separate from whether someone is mentally ill or not. Violence peaks in the late teens and early 20s. Males are 10 times more violent than females. The lower the IQ, the greater the violence, and that it goes down to the moderate retardation range. And the lower the social class, the greater amount of street violence. History of substance abuse is a major risk factor, and then individuals who have less education also goes along with lower IQ, and people who change jobs frequently and change homes frequently are at greater risk for violence. Now, there is stigma associated with being mentally ill. In primetime television, although at best 10% of persons who have a mental illness could be construed as mentally ill, 77% of all people depicted as mentally ill on television are depicted as dangerous. So the perception of very dangerous people associated with mental illness is in the public perception. Now, until 1990, there was considerable controversy about the epidemiologic association between violence and mental disease. Some studies showed it was higher, lower, what have you, but there are now 3 major studies since 1990 which really leave no doubt about the epidemiologic association between violence and mental illness. And the one that I'm going to share with you is by Swanson and his colleagues, and in this study, over 10,000 people were asked if they had been violent in the last year. Violence included getting into a bar fight, hitting someone, child abuse, wife abuse, what have you. And it turns out that if you have no mental illness, there is a 2% likelihood you will have committed a violent act in the last year. If you have a major mental illness, such as major depression, bipolar disease, schizophrenia, there's about a 5-fold increase. But notice that if you are alcohol dependent, you are twice as likely as a schizophrenic to be violent, and if you abuse substances other than marijuana, it is 3 times as likely. So as a risk factor, being male or being substance abusing are more significant risk factors than being mentally ill, even though mental illness is clearly a risk factor. And the mental illness is associated with the active stage of mental illness. So in other words, someone who has residual schizophrenia, then has a psychotic episode, the likelihood of violence is during the psychotic period, not the residual period. So bipolars who are between episodes are no more likely to be violent. It is only during the period of active illness that the risk increases. Another study done by Link in 1992, he compared community residents as a control to people going to an outpatient mental health clinic with a significant major psychiatric diagnosis. Violent offenses over a lifetime were 6 times as great. Getting into fights, use of a weapon, 4 times as great. You get the general idea here. One way to think about dangerousness assessment is to look at 4 components of dangerousness. The first issue is the magnitude of the harm as a way to think about dangerousness assessment, and we can do harm to people and harm to property. Most people can agree that we're more concerned about people and property. Now, we can do 2 things to people: physical harm or psychological harm. Which are you more concerned about? Physical harm. Okay, well, virtually every state legislature agrees with that. They lay down their criteria for civil commitment. Every state legislature has listed a substantial risk of serious physical harm to another as a criterion for civil commitment. Many will not include property harm. Many will not include psychological harm. So that's a cutoff. Doesn't mean we're indifferent to the others, But with respect to depriving someone of freedom, then we are willing to look at this issue of serious physical harm. All right, now let me give you a scenario in which we have a 25-year-old single mother of a 5-year-old son, and she develops classic signs of schizophrenia, is admitted to the hospital, and under today's efficient managed care system, with a 13-day mean length of stay nationally, she responds to antipsychotics, does well, is discharged, takes her medicine for a year. Then, like 50 to 75% of all schizophrenics, she becomes non-compliant and isn't sure she needs the medication anymore. She becomes, frankly, psychotic, and its manifestations at this point are some symptoms where she loses insight, declines medication as an outpatient, declines voluntary hospitalization, and spends 12 hours a day openly masturbating in the presence of her 5-year-old son. Would you want a civil commitment law that would permit her involuntary hospitalization? Some states say categorically there are only 3 categories: physical harm to others, suicidality, or inability to care for self. She's not going to qualify for those 3. Other states are a little broader. Would we want to expand physical harm to psychological harm as a criterion to deprive someone of their freedom? I'm going to paraphrase Lee now, that Lee would prefer to rip this child from his mother's breast, place the child in one rotten foster home after another, and allow this mother to remain the rest of her natural life unmedicated, psychotic, uncared for, and masturbating. Thanks, Lee, for giving me the opportunity to say that. I like to have the opportunity to say that. Now, in reality, when I present this scenario to groups of law students, the majority will say they want to remove the child because they're very civil rights oriented. And it's a very reasonable approach because you're playing off values here, the value of loss of total freedom versus an alternative way to protect the child. So even though I'm fooling around with this, I'm very respectful of that view. My own personal view is I would rather have a broader civil commitment statute which permits involuntary commitment, because I think at the end of it, she would say, thank you, I'm glad I'm now able to be with my child, not psychotic, and so forth. But it does mean stretching the civil commitment criteria to psychological harm. I come from a state, Ohio, which has that provision. Many states are much more rigid. I just share it with you as a way to think about magnitude of harm, and that these are social policy decisions which are made by legislatures. Even though you're on the front line applying the law, there are these policy decisions which inform them. Now, the second factor that I want to mention to you is the likelihood, and in reality, the likelihood is combined with the magnitude. So, if Barbara here had 1 chance in 10 of slapping her colleague in the face during this session due to mental illness, I would be reluctant to civilly commit Barbara. But if she had 1 chance in 100 of killing her colleague, I would be willing to civilly commit her. So what's the point? The point is, although we use the phrase likelihood, in reality we combine the magnitude and the likelihood on a common sense basis. And some appellate courts have recognized this common sense approach. Now let's look at the phrase substantial risk. This happens to be taken from Ohio, but this is very common throughout the country. Substantial risk of physical harm to persons. All right, what does the phrase substantial risk mean? I want someone to give me a number. What percentage likelihood is it if it's substantial risk? Give me a number. Here we have a group of psychiatrists, a group of well-trained psychiatrists, a group of psychiatrists who are spending their time getting further education on violence risk assessment, and you are all over the place. 75% to 10%. If the wording of the law is so vague that we can be that far apart, it is a shame. I am here to tell you what substantial risk means. Substantial risk, this is a definition from a statute, means a strong possibility as contrasted with a remote or significant possibility that a certain result will occur. Substantial risk is differentiated from risk, which is a significant possibility. All right? What does that tell us? Does that tell us anything? Those new words, in terms of, is anyone changing their numbers? Oh, you're all sticking to your numbers, 75 to 10%? Well, I can tell you one thing that it means. In the law, everything is either a possibility or a probability. And a probability means more likely than not, or mathematically expressed, 51%. When they say a strong possibility, we can say for sure it is less than 51%. Because if they wanted to say probability, the law knows how to say that. So categorically, a substantial risk does not require more likely than not. It doesn't give us a number, but it does give us a cap. We know it means less than more likely than not because the word possibility is used rather than probability. Other than that, all I can say is that you use a common sense basis where you have homicide, a 1% risk may be enough, and a slap, you might want a much higher risk. So the point here is that you can't put it in numbers except to know you don't have to think it's more likely than not before you can civilly commit, even though the language says substantial risk. Now, the third issue is imminence. That is, something is likely to occur very soon. Winston Churchill observed, it's a mistake to look too far ahead. Only one link in the chain of destiny can be handled at a time. And if we were to put people in the hospital who might be violent over the next 10 years, that would be outrageous. Over the next day or so is what we generally think of with respect to imminence. With respect to frequency, the fourth component, there are some crimes which are high frequency and they may be low magnitude. Exhibitionism, for example, the average exhibitionist has 150 showings before his first arrest. So this is a very high frequency crime. If it is due to mental illness, as opposed to an ordinary paraphilia, it might justify civil commitment, such as a demented person who, due to their impairment, start exhibiting themselves. So those are the four components to consider. All right, now, when it comes to decision-making, attorneys and doctors approach this differently. The attorney cuts his teeth on the aphorism, better to let 10 guilty men go free than convict one innocent. In other words, in the face of uncertainty, err on the side of freedom. Physicians cut their teeth on the aphorism, above all, do no harm. So in the face of uncertainty, physicians are much more willing to admit to the hospital to prevent questionable harm because their goal is to prevent harm. So we have these two different philosophical approaches which come together. But when we have deprivation of freedom in civil commitment, it is not a medical decision. It is a legal decision because it involves deprivation of freedom. And therefore, the legislature lays out the criteria under which we can deprive someone of freedom. With respect to our ability to predict future violence, psychiatrists have not demonstrated the ability for long-term prediction of violence. And it was said up until the early 1980s that we were wrong 2 times out of 3 in being able to predict long-term violence. In other words, more often wrong than right. No psychological test can accurately predict future violence. They can't even post-dict it. That is, there's no psychological test that'll tell you after someone's committed a violent act that it was done. Clinicians tend to underestimate violence in women. A recent study done in an emergency room showed that clinicians were much more accurate in predicting violence in men and tended to underestimate in women. Now, of course, men are more violent in society, in general, by a long shot, but if someone is severely mentally ill, because our stereotype of women is nonviolent, we tend to underestimate the seriously mentally ill women. I want to talk about the difficulty of predicting infrequent events which have a low base rate. And the example I like to use is a very large hospital with 12,000 inpatients. Such hospitals existed in the 1950s. And let's say we have a known suicide attempt rate of 1/3 of 1% for inpatients. That would mean with 12,000 patients, we can expect 40 suicide attempts per year in that psychiatric hospital. Now, if we are 75% accurate in identifying who will be the suicide attempters, in order to prevent 3/4 of the suicide attempters, 3,000 patients would have to be put on suicide precautions. Now let's say we get a very strict civil rights-oriented new superintendent, And he says, unless you're 99.5% sure, I don't want you putting people on suicide precautions because I don't want the indignity of taking away their belts and so forth. In that circumstance, only one of the 40 suicide attempts would be prevented. So the point here is that either you cast your net wide, which means you have a high number of false positives, or you don't, in which case you miss most of your quarry. And this is the dilemma when you have a low base rate phenomena. Poor ability to predict is that you're going to have to tolerate a substantial number of false positives in order to prevent harm. And exactly where that balance should be drawn is a societal issue. How many people are unnecessarily locked up to prevent a single crime in the community is a social issue, a societal decision. It's not a medical decision. Okay, here is a study by Kozel and his colleagues, published in 1972, and very typical of these studies done before 1980. These were a group of sex offenders in prison that were being considered for parole. And the question was, are they likely to recidivate? And a detailed study, psychiatric evaluation, psychological testing, home visits of social workers was pulled together, and this group then recommended one group as likely to recidivate, that is predicted to be violent, and one group as predicted to be nonviolent. And then if we compare what actually happened, the group that was predicted to be violent, only 35% were violent. In other words, 1 out of 3 that were predicted to be violent were violent within a 5-year follow-up study. Statistically, there's quite a difference, 35% and 8% of the two groups, but for a given individual, now let's look at this from two vantage points. If you take a defense attorney who wants his client out of prison, he says, what? You're going to use data in which you're wrong 2 times out of 3 to keep my client in prison. That's outrageous, and he's got a point. Now let's take a rape victim, and she says, what? You knew there was 1 chance out of 3 that this man would commit another rape, and you loosed him on the community when you had a legal right to hold him in prison. And that's a reasonable perspective. So the question is, what do you do with this degree of uncertainty? As I say, research in this area of long-term dangerousness, we are, even though actuarially we're better than chance, we still have this high degree of greater likelihood of being wrong than right in this type of research. Now, let's take a study from 1988. This involves psychiatric inpatients who had some evidence of violence. And the nature of that violence may have been command hallucinations, threats to do harm, actual physical harm. There was a mean 10-day admission, and then there was a 6-month follow-up where they looked for police reports of crime, readmission after a crime, and so forth. And here you will notice those that were predicted to be violent, 59% were violent. So here we've gone from an accuracy of 1 out of 3 to almost 2 out of 3. And so this newer research suggests that we are not nearly as bad as we once were. We still aren't fully accurate, but if we have shorter term and a group of persons who have a higher base rate of violence, we can do better and doesn't make us look like we're more often wrong than right. Now, one other way to think about this is that the individual has certain characteristics. That's the first assertion. Those characteristics are associated with a certain probability of violence. And third, the probability of violence is sufficient to justify the intervention. And again, even though we might look at those first two, the third issue is the societal issue, which is how likely do they have to be before we are justified in intervening. So one way to think about this is, rather than think about false positive and false negative and how often we're wrong, if you think about it as a risk assessment and not a prediction of violence, then you're not wrong, because you can accurately say this man is a higher risk than this man. No one can say you're wrong about that. If you predict he will be violent, then you're subject to being wrong. But if your risk assessment is sufficient to justify deprivation of freedom, then that doesn't mean that you are wrong.
Dr. Resnick uses a case to introduce some management issues.
An actual case, a man developed a classic paranoid schizophrenic episode. He became more and more fearful. He thought other people at work were talking about him, became more and more paranoid, and he pulled down the shades, holed up in his home, and was afraid to go out. His wife recognized he was mentally ill. He refused to go to a doctor. The wife became so concerned eventually that she got his two brothers to come over, and they physically escorted him to a hospital emergency room on a Sunday. The emergency room doctor called a psychiatric consultant to see him. So far, so good. The man said he was terrified because of these conspiracies, and he was fearful that he was going to be killed. The psychiatrist said, I think you should go into a psychiatric hospital and have this illness treated. And the man said, no, don't put me in the psychiatric hospital. I'll do anything you want. I'll take medicine. Don't put me in the psychiatric hospital. I know they'll kill me if you put me in a psychiatric hospital. The wife was sympathetic to her husband, inexperienced in psychiatric matters, and she said to the doctor, gee, if my husband really doesn't want to go in so much and he'll take medication, why don't you treat him as an outpatient? And the doctor went along and gave him some stelazine, and he went home, flushed the medicine down the toilet because he was convinced it was poison, and 36 hours later stabbed his wife to death in the belief that she had now joined the conspiracy. Their children, aged 3 and 5, eventually in the morning came in to find their mother, and a police SWAT team was called, and he was so fearful he thought the police were in on it, and so forth. Bad scene. I got called in on the case on the question of not guilty by reason of insanity. But this case raises some interesting questions in my mind, looking back on it. Did the psychiatrist who failed to insist on civil commitment on that Sunday fall below the standard of care? To what extent should he have considered the wife's preferences and the psychotic patient's preferences in the decision-making? The point I want to make here is that if you civilly commit over the protests of family, most states have some kind of similar immunity, that if you act in good faith and you hospitalize that patient, you are immune from liability. If you fail to hospitalize and that person does something, you certainly can be accused of falling below the standard of care. Now, in retrospect, it's easy for me to see that this doctor was unduly influenced by the wife. Don't forget, here you are a psychiatrist. You've seen hundreds of psychotic patients. You know what it takes to treat them. The wife is an empathic person toward her husband. She's trying to do right by him, but she can't make that broad judgment on how dangerous he is. The more fearful he is, the greater risk he is of striking out and killing in misperceived self-defense. If he's terrified, as this man was, then that creates a risk to others. So the point I'm making here is not to give excessive weight. Even if the whole family, as a gaggle, 30 people say, don't put him in, doctor, you can sign a medical certificate and put him in if you think it's clear that the risk is that great.
Regardless of what was done, I think the outcome might have been the same in almost every state, certainly in California where I come from. Even if the patient had been admitted, he would have been released by a hearing officer 3 days later or by an administrative judge. And 3 days of antipsychotic medication probably would have been inadequate to restore him to an undangerous state. So I think practically it's very likely that regardless of what the clinician did, although many of us would have chosen to admit him, the outcome could well have been the same. And that speaks to a failure in the law and a failure in the level of sophistication of most of the people who conduct these hearings and have the power to send people home.
Okay, I can't comment on California, which everyone knows is bizarre in its own right, but I don't agree that in most of the country, this man would have been released by a judge in 3 days if a psychiatrist said he's still in acute danger due to his acute paranoia. I think he'd be kept in the hospital 10 or 12 days till the antipsychotics work in the areas that I have been exposed to. All right, now, how quickly is a person likely to commit a dangerous act after the development of a psychosis? In one study, the mean was 30 days. So people don't become psychotic on Monday and kill on Tuesday. This man was psychotic for weeks. Now, at the time you see him, he may kill 1 day after you see him, but it's not the moment that someone starts to become ill that they become dangerous. That usually has to fester a while, and then they think about how they're going to deal with it. It's the exception to go immediately from illness to violence. Now, I want to talk about paranoid psychotic individuals. Paranoid psychotic individuals are more likely to be violent than other psychotic individuals outside of the hospital and less likely to be violent than other psychotics once admitted to the hospital. The reason is that a paranoid psychotic is better put together than a more disorganized psychotic. The individual has a specific target, his misperceived persecutor. He can gain access to a weapon, access to his feared persecutors, and make a preemptive strike. Once admitted to the hospital, the paranoid individual loses access to his target, loses access to his weapons. And the people more likely to be violent as inpatients are the more disorganized psychotics, or the demented people who are more likely to strike out in a haphazard way. Disorganized psychotics, as I say, are more likely to be assaultive in the hospital with less well-planned kinds of assaults. Now, let me talk next about the phenomenon of command hallucinations. In this particular study, which is a retrospective chart review, and for that reason probably overemphasizes violent commands, because if it's just benign, you're less likely to put them in a chart. But nonetheless, you see suicidal commands being substantial. Now, the question, of course, you want to know in predicting violence is, if someone comes into your ER and says voices are telling me to do X, how likely are they to obey those command hallucinations? And in earlier studies, it looked like less than 10% of people obeyed command hallucinations, but a more recent study suggests that up to 40% are likely to obey. Now, there are two factors which are statistically correlated with the likelihood of obeying a command hallucination. The first is a hallucination-related delusion. And this makes sense. Let's go back to Barbara. Barbara, she had a command hallucination to murder her mother. Due to her moral fiber, would at least hesitate. But if she had a concurrent delusion that her mother was an evil wizardess and it was a daughter's responsibility, she's more likely to carry it out. That's just common sense. If you have a delusion which distorts your perception of reality, you're more likely to carry out a related command hallucination. You could figure that out without my telling you that research confirmed it. The second factor you couldn't guess, and that is, of 12 factors looked at, the only one which was statistically significant related to likelihood of obeying is familiarity of the voice. Other factors that you might think would be related, such as how loud are the commands, how frequent are the commands, and so forth, turn out not to have a statistical correlation.
Dr. Resnick's remarks continue on Side B. Side B, Audio Digest Psychiatry, Volume 24, Number 15, returns to Philip J. Resnick on the prediction of violence.
I want to suggest that you would think that God, a voice from God, one might be more likely to carry out than a voice from Satan. But it turns out that there's no correlation between the nature of the personage, God, the devil, what have you. The only two factors are hallucination-related delusion and familiarity of the voice. Now, let's turn to delusions and violence. The delusion which is most likely to be acted on in all studies is a paranoid delusion. And in work just published in the last year, there are other delusions which are correlated with the likelihood of acting on violence. And these are what's called threat and control override. So here are three examples. If your mind feels dominated by external forces, or if you believe thoughts are being put into your head, or you believe that others wish you harm, you are more likely to act violently than other equally severe sounding delusions, such as feeling dead, dissolved, or not existing, feeling that your thoughts are being broadcast, or feeling that your thoughts are being removed by external force. And the reason that these are more likely to be acted upon aggressively is the loss of control, either self-protection or a sense that you are being so controlled, that's so threatening, that there is a need to act. John Hinckley, for his affection over Jodie Foster, shot President Reagan. First of all, erotomania is one of the 6 listed delusional disorders in the DSM-4, and erotomania is a delusional belief that one is loved by another. It's often a rich or powerful person like a politician or movie star, but it's not unrequited love. Erotomania is a delusional belief that that person loves you, and it's a delusion, so it cannot be changed by logic. One erotomanic I recall was a woman, and I gave her a pass from the hospital, and she had an erotomania about a doctor. She went to his home on a Sunday and knocked on the door. The doctor came to the door, and he said, "You again. You've been bothering me. You've been bugging me. You slime ball. You slum scut. Get out of here. Don't darken my doorstep again. I can't stand you. I hate you. Get out." And he slammed the door. She told me this story, and I said, "Did that cause you to think that maybe he didn't love you?" And she replied, "What else could he do? His wife was home." So this is an example of the fixity of delusions, and no amount of confrontation with reality is going to change it, like any delusion. And the point here with regard to violence is that up to 5% of persons with erotomania in one study committed a violent act. The person most likely to be harmed is the person who stands in the way of the relationship. So for a movie star, it may be a bodyguard. For a president, it may be a Secret Service agent. For an ordinary citizen, it may be a spouse. It's the person perceived as standing in the way of the relationship that is most likely to be the target. The second object most likely to be harmed is the love object itself, when the person may feel betrayed. I know he loved me before, and now he's acting like he's rejecting me, and the feeling of betrayal and anger causes the act to occur. In some studies, there is suggestion of a cultural factor. That is, especially Middle Eastern men who come to the United States who are less familiar with American mores may have some encounter with a woman which they take, and this occurred in the Tatiana Tarasov case, which they take to be some symbol of love because of the way American social relationships are more forward than some countries, especially Islamic countries, and then they are positive that this person loves them and feel very angry when they feel a betrayal. There also can be a shift in erotomanics. In other words, they can have one target and 6 months later another, rather than staying fixed on one person. Within schizophrenia, men who have an almost exclusively delusional course, rather than one which is more disorganized, are more likely to be violent than those who have a full panoply of symptoms. And another study suggests that Capgras syndrome, or delusional misidentification, feeling that a person is replaced by an imposter, has a higher incidence of violence associated with it. All right, let's look now at depression. When I mention depression, the first thing that you're likely to think of is suicide risk, as well you should. But depression, people in despair may also strike out at others. Some men may wipe out their families, and women especially are at risk of killing their young children. When Susan Smith killed her children, I had 30 media calls. How could a mother kill her children? What does this mean? It's not complicated. A woman who gets severely depressed and loves her children, and I'm not saying this applies to Susan Smith, but a woman who loves her children very much when she gets depressed. We like to think of mothers as Madonna-like figures who only have loving relationships with their children. But when a woman becomes psychotic or severely depressed, her view of the world may be distorted, unacceptable symptoms may be projected onto her child, and she may then feel she's doing her child a favor by taking that child to heaven with her in her suicide attempt. So whenever assessing suicidality in a woman with young children, you should always inquire, what plans do you have for the children if you were to kill yourself? Some women will say, oh, my husband can look after them just fine. And others will say, oh, I would never leave them behind. Naturally, I would take them to heaven with me. So then, in your risk-benefit analysis of hospitalization, you're looking not only at suicide risk, but suicide-homicide risk as part of that analysis. All right, the next issue I want to talk about is murder-suicide in adults. Murder-suicide in adults, the primary factor to be thoughtful about is jealousy. 75% of men who kill a woman and then themselves, often a wife or especially a rejecting partner, whether a wife or a lover, are likely to have a proprietary feeling of ownership toward the woman, feel wiped out upon the loss of that woman, feel they can't live anymore. They think about killing themselves. They hold the gun up to their own temple, and then they think, why should I lie on the ground while this rejecting wife of mine lies in the arms of her new lover? And they decide to take out the wife or the new lover before themselves. And they don't need to worry about punishment because they're planning to kill themselves. So this is a setup. And in the United States, 4% of murder is followed by suicide. In Denmark, 42% of murder is followed by suicide. And that's related to the fact that we have tremendous gun access and all kinds of killings here, but the majority of killings in Denmark are family killings where you're more likely to have a homicide followed by suicide.
Dr. Resnick discusses mania.
People with manic disease have a higher risk of violence. The nature of the violence is less severe than schizophrenic, and manics are most likely to be violent when restraints are put on them. I don't mean physical restraints, I mean a restriction, I should say. You've got to stay in your room. That's when they're likely to push and shove and get into some kind of struggle when some kind of restrictions are put on them. But the severity of the violence is clearly less than for schizophrenics. Now, with organic brain disease, there are a number of forms this can take. A person can have a history of temper tantrums due to attention deficit disorder. Someone can have a damaged brain due to trauma as an adult. And then we can have individuals with what's called intermittent explosive disorder or episodic discontrol syndrome. This is a very equivocal diagnosis. It remains in DSM-4. It originated with the work of Mark and Irvin, who found actual damage in EEGs, but the way it's actually defined in DSM-4, simply someone who simply has episodes of violence, feels remorse, and it's not part of their character, gets this diagnosis. I think it's a pretty wishy-washy diagnosis myself, but one could consider a trial of anticonvulsants in people who do try this. Now, with regard to epilepsy, if someone has epilepsy, are they likely to be more violent? During an actual seizure, purposeful violence is extraordinarily rare. You can expect someone to have some repetitive thing like opening and closing a button, but someone who goes into a bank with a gun and a note and shoots a teller and says it was during a psychomotor seizure is not for real. Now, epilepsy is still a risk factor because interictally, between episodes, there's a higher risk of violence in epileptics, even when they're not having a seizure. I'm sure because not due to the epilepsy, but due to the same underlying brain problem which causes the epilepsy, it may predispose them to be more violent. There's two things which are kind of hot now. One is stalking and the other is workplace violence. I'm not going to get to workplace violence today, but I do want to share some more recent studies in the area of stalking with you. The majority of stalkers are rejected lovers. Many battered women have been stalked if they try and leave. And stalking often occurs at the end of a relationship. It's more often a situational offense than it is a career criminal who engages in stalking. Often, the stalker has an overvaluation of his love object, cannot tolerate the loss, and rather than mourn and go on to a new relationship, they get focused and stuck. The narcissistic blow is too great for them, and they end up turning that abandonment rage into an engine which fuels their stalking and further harassment kind of behavior. Now, if we look at obsessive attachments, there's one very interesting study I want to go over with you done by Zona. In California, let's take Los Angeles. In Los Angeles, you've got a lot of movie stars and you've got a lot of nuts. You put these together and you have more people being threatened who are famous than any other city in the country. This has resulted in the LAPD, Los Angeles Police Department, developing a obsessive attachment threat unit where several policemen do nothing but respond to threat situations, unwanted attention, and they have started keeping some very nice records, working with psychiatric consultants, and developed this study. And in their first 74 consecutive cases of this unit, they found that 7 were erotomanic, which you already understand, and 32 were love obsessional. Love obsessional category means that the person who's doing the unwanted attention knows the individual only through the media, develops this attachment to a movie starlet, for example, and can't get them out of their mind, sends them letters, goes to their house, makes phone calls, and so forth. And the prototypical victim of this would be a sexy actress, and you have a higher incidence of men. The third category I call the love gone sour category. They have a different name for it in the study, but I think it's actually more confusing, so I prefer to use this. Here we have a prior real relationship with the victim. The relationship fails, and the goal of the stalking person is either revenge or rapprochement, to try and put things back together. And in this category, we have the highest number of threats and harm compared to the first two categories. Erotomanics were mainly women in this study, whereas the love-obsessed category were mainly men. And note how extended a period there was between the attachment and before the erotomanics and love-obsessed acted. There were years that passed, the time before they developed their fixed ideas and they actually acted to do anything. So these are very long-term phenomena. Now, if we look at the given behavior done in this Zona study, we see that in the love-obsessed category, there are the lowest number of threats, and physical harm to property and the victim was infrequent. The greatest harm and activity in the love gone sour category. So some of these other ones where you have these fantasies about the stars, there's a lot of attention, a lot of letter writing, but the actual threats or physical harm to property are infrequent. But the love gone sour category, where there's a real relationship and a person feels betrayed or wants revenge, is where greater harm is likely to occur. Now, these are not all stalking. You see, these are various kinds of activities, so that you can't draw any generalizations about stalkers from this, but just love-obsessed individuals. The next category I want to talk about are threatening letters, and Park Dietz did a nice funded study on letters to famous people, both politicians and movie stars. And he examined thousands of letters and looked at how many of these people approached the star. And it turns out that the presence of an explicit threat in the letter did not have a correlation with whether they were likely to approach the individual. If the letters were more disorganized, they were less likely to approach the person they were writing to. And people who wrote 10 to 14 letters had a 66% likelihood of making an approach. Smaller letters or more letters, they were less likely. But in that particular group, people were frequently making approaches. Two different studies have shown that women are more likely to kill their husbands in the 5 days before their menstrual period than the other 25 days of the month. Now, this is a serious matter because if you take someone with a chronic grievance, take a battered woman, you add that extra level of irritability in someone with serious premenstrual syndrome, and that may push a woman over the edge. Obviously, most women don't have this, and it is serious when it occurs, but you can think about that in your assessment of risk as one factor. If a woman has severe premenstrual syndrome, then during that period of the month, if she is with someone that she's antagonistic with, one can think about that as a risk factor in making judgments. Let me turn now to homosexual panic. This is a phenomenon that when I was a resident in an analytically oriented program, I learned that the origin of all paranoia was Freud's formulation from the Schreber case. And that suggested that a person who was paranoid, let's take a man, loved another man, that was unacceptable. It got changed to I hate him, and that's unacceptable, and it got changed to he hates me. Now, today, I think very, very few people would see this as a psychodynamic explanation for paranoia broadly. But there are given individuals struggling with homosexual impulses, and I've seen a number over the course of my career where they will say, men are trying to sexually assault me during the night. Here's a speck on the sheet. I know that someone was having anal intercourse with me last night, and here's the evidence. And they are very fearful, and in that panic, they can strike out against others. So this is not a frequent phenomenon, but there are individuals, and one should be very respectful that if someone is intensely fearful of being homosexually assaulted, that is a significant risk issue to consider at that time. Post-traumatic stress disorder is a risk for three separate reasons. If someone has flashbacks, they may have a genuine misperception that someone's going to harm them, like Viet Cong, and strike out. Also, there is a higher level of irritability, and there's a high incidence of people using substances to numb their upset feelings. And studies show that veterans who have been in combat and have PTSD have a many-fold increase in their numbers in prison for various kinds of crimes compared to those without. In California, in fact, if someone has a diagnosis of post-traumatic stress disorder, if the prison does not have a treatment program for them, by law they can go to a federal prison where they can get treatment for PTSD. So this is considered in some jurisdictions as a potential mitigating factor and concern about treatment. Let me get to some personality traits now. We had an earlier question about this. There are a series of personality traits which are associated with violence. The first is impulsivity, or the absence of reflective delay, low frustration tolerance, poor ability to tolerate criticism, repetitive antisocial acts, and reckless driving is another one. These people also tend to be self-centered, tend to blame and dehumanize others, and project their difficulties onto others. Now, this cluster of traits by itself would not make someone civilly committable. But the world isn't simple. You may have a person who is schizophrenic, and you're deciding when to release them from the hospital, and if they've got a cluster of these traits, that's one consideration in how violent they're likely to be upon release, even though by itself it would not permit civil commitment. If we turn to the criminology literature now, again, Park Dietz suggested that in the following circumstance we have greater than a 50% likelihood of violence over a lifetime. The first category is one murder with cannibalism. This is your Jeffrey Dahmer situation. One contract murder, 3 forcible rapes of strangers, 1 forcible rape with torture, or 3 assaults of a spouse within 1 year. A lesser risk, just about a 10% risk, would follow from an individual having 1 forcible rape within the year, morbid jealousy and a history of any violent offense, alcoholism and carrying a lethal weapon, keeping a diary describing past crimes, or 3 violent offenses of any kind. I don't actually recall the precise definition of violence in that study, but this is an estimate. It is not hard data. It's kind of an integration of other material.
Are there childhood antecedents of violence? A number of studies have looked at certain factors in children and then looked at the likelihood of violent behavior when the children become adults. So the antecedents identified here are based on research.
Number 1 is parental brutality. Now, this may occur very early in life, when a child is just a few months old, or it can occur when the child is a bit older. Boys and girls respond differently to being physically or sexually brutalized. Boys are more likely to identify with the aggressor and aggress on others. Girls are more likely to replicate the victimization. So girls who are sexually or physically battered are more likely to be raped as an adult. They are more likely to marry abusive men and alcoholic men. Now, obviously, that's a generalization, but there is clearly a gender difference. Any kind of parental seduction, even though it involves no violence, is still a risk factor for adult violence. Truancy and school failures. Now, delinquency as an adolescent is a factor as well. Now, tattoos are very important. You should think of tattoos as a bumper sticker of the soul. And you should, when you record a mental status exam, record the presence of tattoos and the nature of tattoos. And you may want to inquire about why a person got a particular tattoo. Who can tell me the most frequent tattoo? That's right, 26% of all tattoos say mom or mother. Now that may suggest some passive dependent traits, but it would certainly be a different message than someone who has born to kill on their arm, right? So that's worth making a note of as to how they think of themselves and their plans. Other childhood risk factors include arrests for prior assaults, attention deficit disorder. If the first hospitalization is by age 18, that is a risk factor. And then there is the famous triad of fire setting as a child, cruelty to animals as a child, and the third factor is enuresis, or bedwetting. Now, the issue of bedwetting has not stood the test of further scrutiny, but the factors of childhood fire setting and cruelty to animals in a number of studies been consistent. Now, it's important that you inquire. It's very rare that a patient will walk into your office and pee on a burning cat, thereby announcing this triad. So unless you make inquiry about this background, you're unlikely to learn of it. I'm not aware of a gender difference, but girls have a much less incidence of enuresis than boys do, and I think the other factors too are much more likely to be male, but I don't know if there's a gender difference in the study. And in every single study, the best single predictor of future violence is past violence. And we often don't adequately look at a systematic review of past violence. Now, what are some of the types of violence you can think to inquire about? Violent crimes, hospitalizations that resulted from violence, spouse, child abuse, fights in schools or bars, or violent driving disputes you might want to ask about, especially if you're from Los Angeles. Now, in looking at the patient's account of prior violence, a good question to ask is, what's the most violent thing you've ever done? You want to find out about the frequency of violent acts and the thoughts and feelings which came before, during, and after the act. If someone says they're unable to identify their thoughts and feelings, it may be a poor prognostic sign if they are unable to go back and actually put themselves in touch. With regard to each violent act, you can look at why it occurred, who said what was the degree of injury. And what you're looking for here, of course, are certain patterns. In addition to getting information from the subject, him or herself, talking to family is a very good resource because you may learn things from family. The given patient may seek to minimize and deny violence, but a good question to ask family members is, do you have any reason to be afraid of Mr. Jones? And they may give you a lot of reason, threats, prior violence, and so forth. Now, in looking for patterns of violence, there are a number of patterns that one can look at, and some of these are drawn from psychiatric and other types of literature, and let me go through these with you. For example, if someone only becomes violent during acute psychosis, that's a pattern that you want to know about and will help you in assessing violence in the future. If someone becomes violent due to diminished self-esteem, this is sometimes called insult-evoked violence. You say, Mr. Jones, why did you cut the throat of your roommate last night? And he may say, he disrespected me. This may be even shortened to, he dissed me, so that individuals can have a code of death before dishonor, an inability to tolerate some insult to go unaddressed, and are willing to subject their very life to risk to right that insult, to respond to the insult. Another phenomenon is ego-dystonic versus ego-syntonic patterns of violence. In other words, if someone is comfortable with their violence as opposed to, they say, oh my God, I almost killed that person, that was a terrible thing, they feel remorse over it, it suggests it's ego-dystonic as opposed to a level of comfort with it. So you can get a sense about that as they talk about each violent act in their past. Now, the third issue of affective versus predatory violence, some research was done on cats. Now, cats commit violent acts in two forms, affective violence and predatory violence. Now, affective violence is, you see the cat here with his back arched. This cat happens to be next to a Doberman Pinscher in a cage, and this cat is showing a fear response and getting ready to defend him or herself. Whereas this cat is also planning violence, but is about to catch a bird in this predatory mode. Now, some interesting research was done on the various biogenic means in cats in these two states, and some analogy has been made to human beings. That is, can we look at violence in terms of affective aggression or predatory aggression? And affective aggression is where there is this activation of the autonomic nervous system threatening vocalizations, and predatory violence is planned, purposeful, goal-directed. There is not a foreshadowing of the kind of piloerection and other kind of forms, and it is the hallmark of an antisocial personality that he plans to go out, kill a small grocer, and steal his money. That is predatory violence. He's calm, he's cool about it, it's planned and purposeful violent. It's dangerous because there aren't these foreshadowing behaviors. So people in psychiatric hospitals talking about seeing certain muscular signs that you know someone is getting ready to assault you, and you can kind of back off. Well, predatory violence won't give you those signs compared to affective violence.
Dr. Resnick's observations and recommendations continue on the next issue of Audio Digest Psychiatry, produced twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association. This tape is copyright 1995.